first speaker for the conference today. I'm not sure somebody who is practicing functional medicine and is not aware about this personality. She is Dr. Shabnam Das Kar. Dr. Kar is a consultant in functional and metabolic medicine. She works as Director Medical Education at Better Medical Center, Calgary, Canada. She is a co-founder of Metabolic Dietary Solutions Program and has worked as an OBGY, that is obstetrician, and gynecologist in Mumbai for more than 20 years before her transition to functional medicine. We are excited to have you, Dr. Kar, for the kickstart of the IAFM conference with your presentation and your insightful session for the topic that you're holding today is the progesterone and its importance in women health. Over to you, ma'am.
Thank you, Dr. Karishma. That was a very excellent introduction, but just a few corrections. I have closed Metabolic Dietary Solutions because I've moved into brain health now. So anyway, I don't want to waste a lot of time because there's a lot of information I want to hand over to all of you. And who's going to be my timekeeper?
Yes, I'll be that.
Okay. So for many of you today, I'm sure you know a little bit about hormones. Some of you may know a lot about hormones. And I have done my fellowship from the American Academy of Anti-Aging Medicine. I'm a brain health coach. I'm trained in, I'm not going into all of that today because most of it is not relevant to today's topic. But the fact is, there's so much to hormones than just one or two hormones. And if some of you feel today that it's like so much of information, I don't know what's going on, maybe you could also blame me because if I can't simplify it enough, maybe that's my problem. But it's also true that there is a lot of information that you need to know. And some of it may seem a little technical, and I don't apologize for it because our bodies are very complex. So I'm going to start with a PowerPoint slide. And so I do want to have some time at the end for your questions. So I do hope I can be there.
Yeah, I'll inform that before 5 minutes, ma'am. Please go ahead.
So one thing I want to highlight is I'm talking about progesterone today, but as you already, all of you know, progesterone is only one of the hormones, and we talk about a hormonal symphony. So it's not that progesterone is the only one that's important. It's estrogens, DHEA, testosterone, parathyroid, cortisol, insulin, prolactin, all of them, thyroid hormones, all are equally important. So it's a hormonal symphony. It's not just about one hormone, but today I'm just going to talk about one. And just three things I wanted to highlight today. Number one is what are the different functions of progesterone? And what do I mean when I say that progesterone is a neurosteroid? Next is this, the number two thing that I'm going to talk about is extremely important because there's a lot of misinformation around where people don't differentiate between progesterone and progestins. And the third thing is, if you look at traditional hormone therapy, we are always told that, if a woman has had a hysterectomy, she does not need progesterone. So I'm going to actually ask you for your opinion at the end of it, what you think, because progesterone has so many different functions. So it's not just protecting the endometrium. That is the only function of progesterone. Now, I'm not going to spend a lot of time in this because you can just Google for how a woman's progesterone and estrogen levels and all those things throughout a menstrual cycle, how it goes up and comes down. But here, what I want to highlight is you can see that men make progesterone as well. Now, at this point, we are not talking about men and progesterone. And there have been some early studies where they looked at giving progesterone to men, but we don't have all of that information yet. But as you can see here, men, the green line is men. So of course, men don't go through menopause. That's an andropause.
Ma'am, we cannot see your PPT. We cannot see your PPT. Could you please share?
You cannot see. Oh, I am so sorry. I think I forgot to share my screen. I'm sorry about that.
That's okay.
Can you see now?
Yes, we can. Could you please slide?
Okay, so the previous slide was just what I'm going to talk about. I'm coming back to this now, and let me go to, okay. Sorry, my apologies for that. So you can see that progesterone is, different at different, times of a woman's cycle, different time in the a pregnant woman. So progesterone, meaning gestation is pregnancy. So during pregnancy, as you can see, there is a very high level of progesterone being produced. Of course, during pregnancy, the hormonal milieu is quite different. There's a lot of estriol made as well during pregnancy. So it's not just progesterone, but as soon as a woman delivers, her level of progesterone falls drastically, as you can see in the on the slide, which shows pregnancy. And this has a lot of relationship with postpartum depression as well. Then you can see all these, I talked about, what happens in men, and throughout the reproductive age, how progesterone levels can go up and come down and all those things. This is one diagram, which I know you can't read a lot because it's kind of very busy, but this is one of the most important diagrams for us who are in hormone therapy, because you can see that the steroidogenic pathway. So most of these hormones are steroids. That's the chemical structure. And the first molecule in that is cholesterol. Now, I'm sure many of you have heard, see, cholesterol is the molecule from which all the hormones are made. So if your cholesterol levels are lowered because of statins, then you're not going to make enough hormones. Well, the fact is our bodies have the ability to make cholesterol. So this is not as simple as that. However, what I do want to highlight here, and I'm sorry, if you can't see and read all the different things on this particular slide, the fact is there are multiple factors which impact, because if it was only cholesterol from which pregnenolone is made, and you can see all these other hormones made from it, if we see that, okay, someone is low in progesterone or testosterone, we could just give pregnenolone and then expect everything, all the other hormones to be made. But what you can't probably see very clearly here is all these, like pregnenolone being converted to 17-hydroxypregnenolone. That's an enzymatic reaction. And all these enzymes are upregulated and downregulated by multiple different things. And some of the things are listed here. So, it's not so simplistic. Sometimes people think, oh, just give them more pregnenolone and they're going to be fine. No, we cannot guarantee they're going to be making the downstream hormones if you just give them pregnenolone. And pregnenolone is probably the last hormone we are going to give. Sometimes when we correct all the other hormonal imbalances, pregnenolone comes up. So here we are not talking about pregnenolone, but this is just something I wanted to highlight. And this is a chart which, for our fellowship, we had actually learned it up, and I hadn't learned it when I did my OBGY MD. So this is something very important. What is important to understand is we use a simpler one for our patients because we didn't want them overwhelmed with all this information. There are 3 different types of estrogens, E1, E2, E3. Progesterone is one. So the estrogens can get interconverted, but I'm not going to go into that today. So what are the functions of progesterone, and why have I highlighted, endometrial protection against unopposed estrogen? Is because, you are told that if a woman has had a hysterectomy, she does not need progesterone because she does not need her endometrium to be protected, because unopposed estrogen, and that is one of the reasons why in women with PCOS and anovulation, they are at a higher risk for endometrial cancer. So unopposed estrogen, if they don't make enough progesterone, that is a risk factor for endometrial cancer. But progesterone has all these other wonderful functions. The pregnancy, of course, the name itself tells you. Then bone formation, myelination. So myelination is myelination of the nerves, neuroprotection, metabolism. Progesterone is extremely important for metabolism. Immune system. Now, because of the ongoing pandemic, we have become a lot more conversant with what is going on with the immune system. As you probably know, women and men have very different immune responses. And some studies have shown that in the ongoing coronavirus pandemic, women did better. And particularly women who were not in menopause, they did better. So the immune response is very different in men and women. And interestingly, there were some interventional studies. The only thing is the clinical trials have not been published yet. So I don't know what happened. So they did give a relatively high dose of progesterone to even men as an injection, men with the coronavirus infection. but we don't know what happened. So, but then the thing is, it's important to remember. And estrogen has these wonderful actions on different, immune system and all those things. But it's important to know that progesterone is not just something that protects the endometrium. It has all these other wonderful actions as well. So again, no apologies for this complex slide. What do I mean when I say that progesterone is a neurosteroid? Neuro as in nerve, and steroid, it's its chemical structure. So our brain makes progesterone, and not just progesterone, there are other neurosteroids as well. One of the progesterone derivatives is something called allopregnanolone. And there have been some studies where they are trying to use allopregnanolone as an anti-epileptic medication. So oral progesterone gets converted to allopregnanolone better than transdermal. So that's just one thing you need to keep in mind, because when we use hormone therapy, again, I don't have time to go to all the misinformation about hormone therapy that you may have heard. And many of my OBGY colleagues are not even aware of. The moment you bring up the term hormones, they'll tell me, oh, that's bad, right? I said, what do you mean? What is bad about hormones? It depends on what type of hormones you're talking about. So using estrogen, 17-beta estradiol on the skin, and oral micronized progesterone, that is the standard hormone therapy now. It is not the conjugated equine estrogens, the horsey estrogens by mouth, and it is not the medroxyprogesterone acetate. I'll come to talk about a little bit about the progesterone part of it, the progestin part of it. So when I say that it's a neurosteroid, what it means is our bodies don't have redundancies built in them. So if the brain is locally making progesterone, and of course, there are a whole bunch of other neurosteroids as well, in addition to what is being made in the ovaries and the adrenal glands, definitely progesterone in the brain has some major action, because otherwise Mother Nature is not going to just sit and make something that has no function at all. So that is something, all these steroid hormones being neurosteroids, this is information that has not gone to a lot of doctors, even neurologists. Even gynecologists, of course, don't know it. And why this is important, I'm going to come to that as well. So the neurosteroid action of many of these hormones is very important, because we have a lot of mood disorders, and particularly in women who are in the menopausal transition. So that's important to keep in mind. Now, this is a survey which was done in the US. So many of you may be familiar with the straw, that is the stages of reproductive aging. Now, the reason I didn't bring up that slide on straw is I don't find that straw, the different stages of reproductive aging, helps in clinical care, because it's not like these are like silos. Someone is in early stage, someone is in mid stage, someone is in late stage. The other important factor is, age at menopause varies from different ethnicities. In the predominantly Western population, the average age is 51. One study from India showed that it is 46, but then, India has a population of 1.3 billion people. And this was not a study representative of the whole country. But it's still, there was one study which showed that it is about 46 in Indian women. So everything hits South Asians earlier, whether it's cardiovascular disease, diabetes, and all of that. But what I want to highlight in this list of symptoms is, this is what women were asked, and these were the top 20 symptoms they talked about. I am more forgetful. I am irritable. I'm grumpy, less interested in sexual activity, sore breast, harder time concentrating, anxiety, skin is drier. You can see this whole list. And I'm sure you notice how many of these are sort of mood disorders and related to mood and anxiety. And the treatment for all these conditions is not an antidepressant medication. But unfortunately, even today we had a patient at our clinic here in Calgary. She said, my doctor says I don't need hormone therapy because I don't have hot flashes. Now, not everyone has hot flashes. And particularly in Asian countries, hot flashes is not as common as pains and aches, anxiety, mood disorders, chronic insomnia. Those are much bigger problems for a lot of women. And again, I'm talking based on somewhat limited data. There's not a lot of data from India. I have asked a lot of my colleagues. Hopefully things will change. We can do a survey for women in India so that they are provided with the right support. But the unfortunate thing is the knowledge about hormone therapy is not as common in the amongst the OBGYs. Endocrinologists know to some extent, but people don't usually go to an endocrinologist for hormone therapy. So this is one area where we need to do a lot of work. So here is what a lot of people are not aware about is whenever you hear any conversation about menopausal transition or menopause or any of that, the conversation is always, oh, estrogen is going down. Now, there are 3 different estrogens. E2, estradiol, is the estrogen with 400 different functions. E1 is the potentially cancer-causing estrogen. E3 is a very mild estrogen, which is the predominant estrogen in pregnancy. But the point I want to highlight here is it's not like a gradual estrogen levels fall and progesterone levels fall and FSH goes up. In the menopausal transition, and we have actually seen this hormonal chaos that happens, because in Canada, unlike in India, we can get a lot of blood work done through healthcare. Patients don't have to pay. In India, getting an E2 or E3 done is very expensive because they have to be sent abroad. So I've stopped doing E1 and E3 for my patients in India. E2 and progesterone, yes. So here you can see that FSH going up is considered to be one of the earliest evidence of someone going into menopause. But menopause, by technical definition, is a retrospective diagnosis. So what do I mean by retrospective? It means if someone has not had a cycle for 12 months, then the woman is said to be in menopause. Now, she could be 6 months into her menopause and have a whole bunch of symptoms. Maybe she's still cycling irregularly, but still she has a whole bunch of symptoms, but she's technically not in menopause, so she doesn't qualify for hormone therapy. That is not right. Now, one of the things that happens, and if you're interested in knowing more, there's a very good book by Dr. Geraldine Pryor called Estrogen Matters. Dr. Pryor is an endocrinologist from my country. She's in University of British Columbia. She's written an excellent book, and she is someone who's highlighted that during the menopausal transition, a lot of women have this problem of very high estrogen levels and comparatively very low progesterone levels. So during that time, a lot of these women have irregular cycles, but they still are having cycles. So this is going back to my MD, and gynec endocrinology. We say that if a woman is still having some bleeding, that means she still has some estrogen. But what happens during that transition period when there is this hormonal chaos going on is the difference between the estrogen levels and progesterone is very drastic. So many of these women actually need progesterone only during that time. And progesterone we can actually give cyclically so that we can regulate the cycles. And I'm not going into all of that. But this is something important to know, because just because someone is nearing the menopause, it doesn't necessarily mean it's only estrogen levels going down. Sometimes estrogen levels can go up dramatically, and we've seen it here. In fact, one patient, we had to go through all her cosmetics and everything, wondering whether, she was accidentally getting some estrogen from somewhere else. But it turned out it was her own body making the excessive amount of estrogens. So of course, she did not need estrogen at that point. She needed more of progesterone. And here is the next important thing, because the difference between progesterone and progestin, this difference is very often you will not find it in clinical studies, in many papers. Even a lot of doctors, unfortunately, don't know the difference between the two. So here are the chemical structures. Now, you don't need to know a lot of biochemistry. I'm
10 minutes to
sorry?
go. 10 minutes.
How many minutes?
10 minutes.
Sorry?
In total of 10
okay,
minutes.
10 minutes. Okay, I'm going to rush.
Yes.
So progesterone versus progestins, as you can see, the structure of the two are very different. So progestin is the synthetic one, the one that was used in the Women's Health Initiative study, the bad one. And progesterone is what your body makes. Now, can you guess what this molecule is? The third one that is on the screen now. You can see how different it is from progesterone. Well, this is testosterone. So you can understand how different MPA is from progesterone. So how did we expect that progestins like medroxyprogesterone acetate are going to show the same effects as progesterone? Progesterone is what our bodies make. So comparison between the two. So if you ever come across anyone saying hormone therapy is bad, the bad part comes mostly from the medroxyprogesterone acetate and from the oral estrogens, because the oral estrogens contain a lot of E1, and it's a mixture of a whole bunch of different estrogens made from pregnant mare's urine, pregnant horse's urine. It's nothing to do with humans. But 17-beta estradiol is the estrogen that our bodies make. So you can see in this risk, it increases your clotting risk. So VT is venous thromboembolism, and raises cardiovascular risk because the MPA also triggers the mineralocorticoid receptors. So I just want to rush through some of the clinical studies because that is more important for you. So menopause, sleep, and hormone therapy. Now, the KEEPS, Kronos Early Estrogen Prevention Study, if you have studied anything about hormone therapy, KEEPS trial is one of the major ones that you must have gone through. In this particular studies, one group was given oral equine estrogens and another one was given transdermal plus cyclic progesterone. So prometrium is the progesterone, it's not the MPA. Now, what they found is, of course, both of them had better sleep, but sleep disturbances improved more in the transdermal estrogen than the oral equine estrogen or placebo. But what I wanted to highlight here is in the transdermal group, they were also given cyclical progesterone. So that is important to remember. So it's not just one hormone causing the effects. And the other thing is very often, when there is chronic insomnia in the menopausal transition, people are told that, oh, do you get hot flashes? You get hot flashes, that is the reason you stay awake. So what they found in this particular trial is it was not related to the hot flashes at all. This is again, Dr. Geraldine Pryor. I mentioned her name earlier. One of her studies, women in the 44 to 62 years of age, vasomotor symptoms of menopause were, they were much better on 300 milligram of oral micronized progesterone at bedtime daily. Now, progesterone ideally is given at bedtime because it reduces anxiety and it helps a lot of women sleep better. Now, you can see that the dosage is not a small dose. 300 milligram is kind of a little on the higher side. In India, you do get Susten, which is 200 milligram and 100 milligram. But we use a lot of compounded hormones because all women do not do with 300 milligram. So if someone needs 350, then it's a problem in giving her something. Depression and hormone therapy is another big area. As you can see, being on hormone therapy, help their depression much better. A lot of women do much better with their sleep, with anxiety. A lot of data is there. I'll just rush through that. Now, considering all of this, what would you say? Would you say that women still need progesterone after a hysterectomy? So this is just a recap of all the different functions. So obviously, I'm sure most of you will agree that they do need progesterone. As I usually say, when a woman loses her uterus at hysterectomy, does she also lose her brain? So here, there are about 17 different references you can go through. And do I have time for questions?
Yes, ma'am. Thank you so much for your insightful knowledge on progesterone. I have certain questions from certain participants.
Go ahead.
Yeah, Mohit Bajaj is asking, his wife is asking, I had a hysterectomy at the age of 37 years. Now, after 5 years, I have multiple issues. What should I go for as in hormonal therapy?
Okay, so number one is this is not medical advice because you're not my patient. But if you had a hysterectomy at 37 for a non-malignant condition, particularly if the malignancy is not related to any hormones, it is unethical not to recommend hormone therapy to you. So don't let any doctor tell you, you did not have cancer, you did not have breast cancer, you did not have endometrial cancer. Cancer cervix is not a hormone-dependent cancer. So depending on why you had the hysterectomy, if it was for a benign, non-cancerous reason, and particularly non-cancerous as in not hormone-dependent, you should have hormone therapy. So early menopause is one of the most important indications.
Thank you, ma'am. Dr. Vishnu Satish is asking, does Vitex has a role in ovulation?
What is Vitex? I'm sorry, I don't know.
Okay. Somebody else is asking how the hormones affect our digestive system. Do they affect the secretion of digestive juices like HCl, bile, pancreatic enzymes, and the motility of our intestine?
So I'm not aware of the relationship of digestive juices with hormone therapy, but motility is definitely affected by hormones. And not only in women, actually, gut motility in men is impacted by testosterone as well. So I think that's, how am I doing for time? I think that's
Yes,
all, or do we have more questions?
4 minutes remaining.
Okay.
I'll just push. Okay. Gitika Gutiki is asking why progesterones or hormones can be prescribed to our patients post hysterectomy, which are safe in young females.
I think I've already answered that question.
Okay. So,
Yes, of course, you can recommend progesterone depending on what, what she had the hysterectomy for.
okay, ma'am. These are the only questions.
Is there no known causes of early menopause onset at 42? Sometimes the biggest factor deciding on age at menopause is genetic as well. So if the woman's mother, her grandmother, they had early menopause. And one more factor is primary ovarian insufficiency. That can also cause early menopause. And of course, all the surgical menopause can also be early. And yes, of course, HRT is an option, like I said. What the only contraindication for HRT is hormone dependent cancer, which is recent. So if a woman has had a breast cancer and she's cancer free for longer than 10 to 15 years, I'm more conservative, so I go more for 15 years. She can still be recommended hormone therapy, but she has to be, all women on hormones have to be monitored very carefully. But someone who's had cancer in the past, she has to be monitored even more. And that monitoring, again, I don't have time to go into all of that.
Yeah.
Okay,
one last question.
that's it.
Yeah, one last question. People are asking on the unknown causes, like if there is no cause to early menopause onset at 42, would HRT be an option? And is early menopause a red flag in any kind of treatment modality in the further future or affecting other things?
Absolutely. So one of the areas that early menopause, particularly surgical menopause, affects is cognition. So brain function, your risk for dementia, mood disorders. Earlier, there was this impression that if a woman was, only had a hysterectomy and both her ovaries were retained or one ovary was retained, then she did not go into menopause. That is not true. Recently, a lot of papers have shown us that a woman goes into menopause very soon. And these are the women, particularly when they're young, less than 40 years of age, not giving them hormones. And it's important to let the woman decide whether she wants the hormone therapy or not, rather than giving her the scare, you're going to get cancer and hormone therapy is bad for you. That is the myth that I really want to dispel. You have to know what hormones you're talking about. Oral estrogens, MPA, no, we don't want to do that. But transdermal estrogen, oral micronized progesterone, definitely.
Thank you so much, ma'am, for your insightful session and your knowledge on progesterone. And thank you for giving us a wonderful presentation on the same. Thank you.
Thank you.
Thank you.